My dear students, in this video, I am going to discuss with you some salient points regarding culture negative sepsis. It is feared that almost 30 to 40% of sepsis in many parts of the world is culture negative, which means that although the patient's clinical condition satisfies the diagnosis of sepsis, yet the culture does not yield any positive result. Now, what are the reasons and what we do in such cases? Let us start with this case. A 50-year-old male with type 2 diabetes and hypertension is transferred from a peripheral hospital with fever, hypotension, and altered sensorium. He had received ceftriaxone with peptides before referral to that higher center. During initial assessment in the ICU, his vitals were found to be as by blood pressure 82 by 46, heart rate of 118, respiratory rate of 28, temperature of 38.9. Patient was confused with cold peripheries, bibasal crickles, and mild abdominal distension without any guarding. Q SOFA was 3 by 3. Initial investigations showed ABG with a metabolic acidosis with a lactate of 4.8. The labs revealed WBC of 18,000, platelets of 95,000, creatinine 2.1, bilirubin 2.4. Imaging showed chest X-ray with bilateral patchy opacities. Cultures were set, two sets of blood cultures, urine culture, and tracheal aspirate post-intubation. And the provisional diagnosis was septic shock with multi-organ dysfunction. Now, during the management, it was immediately the patient was managed by securing the airway since the patient had a GCS of 10. Fluid resuscitation was started at 30 ml per kg with ringer lactate, followed by noradrenaline infusion started to maintain a MAP of more than 65 mmHg. Empiric antibiotics were escalated to meropenem with teicoplanin. Stress dose steroids were deferred initially, source control was planned. Over the next 48 to 72 hours, watching by the clinical course, the hemodynamics improved. The map showed more than 65 mmHg on low dose vasopressors. The lactate was normalized. The clearance was adequate. The renal functions became better. And all the cultures which have been sent reported no growth. So this patient fulfilled the sepsis 3 criteria, even improves with therapy, but the cultures yield negative result. So therefore, these are the typical patients whom we can label as culture negative sepsis. Now, why the cultures become negative? Looking into the importance wise, the first point that needs to be highlighted is the antibiotics before cultures, and this is the most common cause why the cultures come negative. Even one dose of antibiotic can sterilize the blood and make the bacteria disappear from the blood. Although they can remain in the tissues, the infection can persist in the tissues, but in the blood there will be no evidence. So this is one cause. And the referral bias, because the patients have already arrived already treated, and therefore unless and until it is documented, and many a times in our country it is not documented what the drugs the patient receive before referral, it may is the one of the most important causes for which the cultures are negative despite the presence of sepsis. There can also be difficult to growth or missed pathogens because of reasons other than the technical reasons. That is, there are some fastidious bacteria which grow intracellularly. There can be anaerobes, there can be fungi, mycobacteria, the viruses. So these are some of the organisms which cannot be detected on routine cultures unless precautions are adopted or unless certain special improvisations are made. It may not possible to detect. But more important to this is the wrong site or poor sampling. Instead of a deep focus on the blood, we tend to pick up the blood from the wrong site, inadequate volume, or delay in the transport, or suboptimal technique being used during the time of transport. So these are some of the technical causes. As well as there are certain non-infectious sepsis mimics, which can be acute pancreatitis, pulmonary embolism, vasculitis, adrenal crisis, thyroid storm, HLH, drug reactions, ischemic bowel. So all of these are also rather insignificant causes, but causes of culture negative sepsis. One needs to keep them in mind. And if it is culture negative sepsis, it is possible to rule out some of them, at least if not all, by taking help of uh, other tests, especially the biomarkers. So, what are the strategies? Because since we know that prior antibiotic can cause disappearance of the bacteria from the blood and hence yield a culture negative report. So, what strategies can actually improve the yield despite prior antibiotics? One most important factor to be remembered here is the adequate blood volume of 8 to 10 ml per bottle. Some studies recommend even 15 to 20 ml per bottle, which of course may be logistically difficult at times, but 8 to 10 ml per bottle from two sides, and the volume beats the timing, because even if you are late, if the volume is more, then probably we can get some correct report. Culture from the source, from the drain collections, the sample of the infected tissues, the remove and culture lines if suspected. So the source from which the culture is taken, that is very important. If we can identify the correct source from where we need to take the culture, so where there can be some amount of the organisms or the bacteria can be present despite prior antibiotics. So it need not be from blood, it will disappear, but it will be remaining at various other sites. And we should be able to collect the source from those sites. Then use adjunct diagnostics like molecular panels where PCR is available, fungal biomarkers if they're available, in selected cases, serology to help us or aid us in diagnostic. We have to remember that blood culture positivity drops by nearly 30 to 50% after a single antibiotic dose. And the median time to sterilization in cases of gram negative bacteremia is 1 to 2 hours, and in gram positive bacteria is 2 to 4 hours. Now, this much of time is often lost, very often lost, when a patient moves from one hospital to another or is referred from a peripheral center to a higher center. And pneumonia, intra-abdominal sepsis, and soft tissue infections are the ones which are most affected by this antibiotic administration and hence yield a culture negative report subsequently. If we talk about the difficult to grow or fastidious pathogens in sepsis, these bacteria require special media, prolonged incubation, or specific environments, or else they do not grow in vitro. Key examples are like Haemophilus species Neisseria, Legionella hemophilia, Brucella, Bartonella, the Hasse group of organisms responsible for endocarditis, and so on. And why the cultures fail? Because poor survival in standard blood culture bottles. Sometimes they have slow growth because we have span from days to weeks. Sometimes they are suppressed by even minimal antibiotic exposure. And there are certain clinical clues by which it is possible to know, like if the patient is having a subacute course, if the patient is having endocarditis with negative blood cultures, if the patient is having pneumonia which is not responding to beta lactams, if the patient is having occupational or animal exposure. In all these cases, it is possible to suspect the growth of fastidious or difficult to grow pathogens in the patient, leading to negative culture. There are some organisms which live inside the host cells and they are not free in the blood, like Rickettsia, Chlamydia, Coxiella burnetii, Legionella, Mycoplasma, and they also yield negative report, and they cannot grow on routine agar. They need cell cultures or molecular tests, and blood cultures are almost always negative. So ICU clues will be in patients who have severe pneumonia with hyponatremia, high ferritin, transaminitis, vasculitic rash, exposure history to insects or ticks, livestock, air conditioning systems, etc. for rickettsial diseases. Then, if there are anaerobes, anaerobes die on exposure to oxygen. So, bacteroids, clostridioids, fusobacterium, peptospectrus, if these are causing infection, they may give culture negative report, because improper transport, delayed processing, blood cultures less sensitive than deep samples. So, all of this causes disappearance of these bacteria, and hence their cultures will fail. So we have to think anaerobes when the patient is having intra-abdominal sepsis, necrotizing soft tissue infections, aspiration pneumonia, or foul smelling discharge or gas on imaging. So in those cases, clostridioids you have to rule out. Then fungal pathogens are also important causes. They are frequently missed unless they are specifically looked for, like Candida aspergillus or endemic fungi. So they also have low sensitivity of blood cultures. The deep organ involvement without fungemia causes negative report in the blood. Their slow growth is particularly responsible. But there are certain ICU red flags like persistent sepsis despite broad spectrum antibiotics, multiple lines, TPN, recent surgery, neutropenia or immunosuppression, and of course, high beta D glucan or galactomannan is indicative of their infection. Mycobacteria is another cause, which cause of prolonged culture negativity, either because of Mycobacterium tuberculosis or non-tuberculous mycobacteria. And the cultures fail because they take time to grow, require special stains and media, and blood cultures are usually negative unless the disease is disseminated or miliary. So ICU clues arise from subacute sepsis, weight loss, lymphadenopathy, unexplained ARDS or septic shock in areas which are endemic to tuberculosis. Viral sepsis, it is not detectable on bacterial cultures ever because it is virus. Important examples we know, influenza, SARS, CMV, HSV, dengue. But we get a lot of clinical clues which are comparatively easier to diagnose, like leukopenia, thrombocytopenia, high ferritin, shock with minimal bacterial markers, particularly the lack of rising of procalcitonin, poor response to antibiotics, etc. But other than that, when should we suspect a sepsis mimic? We know that there are a lot of sepsis mimics, and there is another lecture on sepsis mimic available in the YouTube. One can go through that. So, whenever there is no identifiable source despite imaging, cultures persistently report negative, poor or paradoxical response to antibiotics, extremely high ferritin. The cytopenias are there instead of leukocytosis. If there is rapid steroid responsiveness, if steroids are used, they are found to be extremely useful. High lactate with minimal infection markers. So these are the conditions where we need to suspect a sepsis mimic. Biomarkers are of limited value, but they can be helpful at times. Particularly if a procalcitonin is there, we should be interpreted. If it is often low or falling, we should suspect a sepsis mimic and not a true sepsis. CRP can be high because CRP is non-specific. Lactate is a severity marker, but not an infection marker. So lactate is not reliable. Ferritin, if it is very high, we think of HLH. So, what should be the diagnostic approach? One, we have to reinterrogate the diagnosis, that what is the source and am I sure that it is infection? Next, we look for harder for the source by repeated focused examinations. We look for the lines, wounds, joints. We do an imaging of the CT chest, abdomen, pelvis. Sometimes, if it is not detected anywhere, we have to remember that sinuses can be the source of infection. So, an imaging of the paranasal sinuses may give us clues. Ultrasound for collections, particularly if it is abdomen or if there is injury in the chest or in the other extremities. Remove and culture devices if we suspect that the devices or the or the devices are responsible or may be responsible. We have to think beyond routine cultures and try with respiratory PCR panels, fungal markers with galactomannan and beta D glucan. Go for TB workup, viral studies, and serological studies, depending upon the clinical presentation in selected cases. There are certain red flags considered sepsis mimics, like if the patient is not having fever, disproportionate cytopenias, very high ferritin, steroid responsiveness, refractory shock with normal lactate. So all of these point towards sepsis mimics. So what should be the antibiotic strategy? The initial phase always treat as true sepsis with broad spectrum antibiotics, source directed if suspected, and early and adequate dosing. There is no doubt about that. But reassessment is very important at between 48 to 72 hours. And reassessment can be resolved by asking three important questions: that one, is the patient improving or not? Is a source identifiable or already identified or not? And is infection still the best explanation of the patient's condition? And next, it is important for to know the de-escalation principles, that we have to narrow the spectrum if clinical response is good, stop one agent at a time in combination therapy, and shorter duration often suffices if there is no deep focus. So if alternative diagnosis is suspected or if alternative diagnosis is reached, then we have to stop the antibiotics. Role of biomarkers, as I said, that procalcitonin is helpful to stop but not to start antibiotics. CRP, the trends may be useful, but they are non-specific. Lactate is indicator of severity and perfusion defects, not infection. And WBC is, of course, less reliable because there can be leukopenia also in sepsis. So if you look into this flowchart, sepsis, suspected sepsis, go for cultures, start with the routine diagnostic test and then start empiric antibiotics. You obtain appropriate cultures based on history and physical exams. Productive cough, you obtain tracheal aspirate or BAL, blood cultures, respiratory viral panel. In abdominal pain, you take blood cultures, urine cultures, stool cultures, enteric toxin or antigen toxin if it is clinically appropriate. So depending upon we continue with the empiric antibiotics with cover for gram-positive, gram-negative, anaerobic, viral and fungal pathogens as suspected. And if it is culture positive, it goes, you look for the species, you know the sensitivity, and then accordingly you go for a narrow coverage. If it is it is culture negative, you have to, if and you consider any alternate diagnosis, you limit the therapy, the discontinue MRSA pneumonia. If MRSA nears swab negative abdominal infection, you limit antibiotic course to 4 days after source controls, etc. And depending upon the clinical impression of whether the patient is not improving or improving, you change your plan. If the patient is not improving, then please do not de-escalate. Consider broadening the coverage, consider fungal infection, evaluate for source control, consider MDR pathogen, consider double coverage for gastro and urinary infections, etc. If the patient is improving, then you consider narrowing coverage, and if not negative, and cultures after 24 to 48 hours, and narrow coverage to the most likely source and the specific organism. So discontinue anaerobic coverage and also eliminate anti-MRSA therapy if there is no for SSTIs without any purulence. So my take-home message would be that culture-negative sepsis is very common. Prior antibiotics are the leading cause of culture-negative sepsis. This has to be treated early, like culture-positive sepsis in the early stage. Mandatory 48 to 72 hours diagnostic pause is necessary, in which we need to assess that how things have fared up, how the clinical course of the patient has been. Always consider sepsis mimics and try and take the help of biomarkers or other diagnostic models to exclude them. And always you have to remember that de-escalation is not a failure. De-escalation is an evidence of good ICU care. So we should not be uh, afraid of de-escalating antibiotics if we doubt our diagnosis and if we think that the patient may not have sepsis in the wake of culture negative report. So more about culture negative sepsis, one can read this beautiful review article written by Marin Koleff and Jonathan Thorndike. It was published in 2020 in Current Opinions in Critical Care. And a bit of information I have taken it from this review article. So one can go through it. It will be extremely useful for the students. Thank you.